Good afternoon, everyone. I hope everyone can hear me. My name is Richard Cleaver, and welcome to SHEAC's, the Stamford Health Education Awareness Charity's first webinar. I see we have lots of attendees already logged in, and the number doesn't seem to be rising, so we'll make a start. First of all, many of you may not be familiar with having a Zoom in webinar mode. Many of us, I think, are now familiar with doing Zoom meetings since lockdown, but maybe not as a webinar. So hopefully you can all hear and see me, and you will be able to see the panelists as well. As they speak, I can see 3 of them here, and you won't be able to see each other. That's exactly how this works. And this is going to be recorded. So, but because you can't be seen or heard, your privacy is not compromised by the fact that we're recording this webinar. It will be available on Zoom in about 48 hours time. After each speaker has done their speech, their presentation, there will be an opportunity for questions and answers. We can't guarantee that there will be time for all of them to be answered. However, we will note down all of the unanswered questions, and we will add the answers onto the back or the end of the web version of this webinar. Okay. When it comes to questions and answers, you should find that as we are in webinar mode, there is a Q&A button at the bottom of your screen. Okay. And I'd just like to do a quick introduction of the Stamford Health Education and Awareness Charity, as you may not have heard of it before. Stamford, this charity was formed recently to take over the charitable work of the patient groups of the former Sheep Market, St Mary's and Little Surgery GP practices, which of course now consolidated into the Lakeside practice in Stamford. And so we are relatively new, as Lakeside is relatively new. The charity is designed to support and facilitate educational events for all the community in Stamford and the surrounding areas. We have a program of events planned up for the next 6 months and penciled in for the rest of the year as well. We'll let you know what they are. We hopefully will be able to add your email addresses to our mailing list, so we can keep you in touch with all of those events coming forward. But they will be on various subjects of interest across the spectrum of health education and awareness, including health and retirement, mental health, health issues in childhood and adolescence, and health promotion and other issues of that nature. And we're always open to suggestions for any subjects that we might cover that would be of use, particularly locally, because we are a locally based charity. So I think that's enough introduction and enough from me. I'd like to introduce, please, our first speaker, who is Dr. Faye Riley, who is the Senior Research Communications Officer at Diabetes UK. So, Faye, please, let's
Hello.
Hi.
Hi, thanks, Richard. Yes, so I'm Faye, and I don't know why I feel the need to introduce myself as well. I work in the research team at Diabetes UK. I also live with type 1 diabetes myself, and I'm here to talk to you today about what we've learned so far from the research on coronavirus and diabetes. So there's been an enormous amount of research coming out over the last year. We went from a year ago knowing absolutely nothing to where we are now, where there's tens of thousands of publications about COVID. But of course, there's still a lot we don't know. So I really wanted to kind of take you through the 5 headlines around diabetes and coronavirus. So the first one is that we know from the evidence so far that people with diabetes are no more likely to catch coronavirus in the first place compared to people without diabetes. And that was a concern right at the beginning of the pandemic, because diabetes does affect the immune system. So over time, high blood sugar levels can weaken the immune system's ability to fight off bacteria and viruses. The complications of diabetes over the long term can also damage your blood vessels, which can make it harder for immune cells that are carried around in your blood to get to where they're needed in the body, which can also make it harder to fight off infections. So that's why people with diabetes find that their wounds can be slower to heal. In particular, we see that with foot ulcers that can kind of become infected and become problematic. And there are certain infections that people with diabetes are more likely to catch, certain skin and tissue infections and some conditions like pneumonia. But as I've said, the good news is that from everything we've learned, there's no evidence to suggest that people with diabetes are more likely to catch COVID. We do need to bear in mind that what we know changes rapidly, and coronavirus testing wasn't widely available for the first few months of the pandemic. So that has made it hard to know exactly who has been infected. It's also difficult to know how many people may have been infected but been asymptomatic. So this means that there is more work to do to fully explore whether certain groups of people are more susceptible. And at Diabetes UK, we're funding some research into this. So at University of Bristol, we're funding Professor Kathleen Gillespie, who is giving coronavirus antibody tests to around 5,000 people living with diabetes to try and get a first clear picture of infection rates within people with diabetes. So we should know more on that soon. But for the moment, that's good news that we don't appear to be more susceptible. The second thing that we do know much more about is that if people with diabetes do get coronavirus, then they are more at risk of needing to go to hospital or sadly dying with the virus. So most people, including those living with diabetes, will experience mild or moderate symptoms from coronavirus. And of course, we know that old age is by far the most important, the dominant risk factor when it comes to risk from coronavirus. But there is now quite a large body of research evidence that shows that people with diabetes have a higher risk even after you've removed the impact of age. So that tells us that diabetes alone and the harm that that's doing to the body is having some kind of impact on how we are affected by COVID. One of the biggest studies looking at this came from NHS England, which was published in the summer of last year. So they looked at everyone who had died in hospital with coronavirus in England during that first wave between March and May of last year. And they found that a third of all those deaths happened in people with diabetes. They then found that when you compared the risk of someone with type 1 diabetes to someone of the same age and of a similar background that doesn't have diabetes, the risk of dying was around 3.5 times greater for people with type 1. For people with type 2 diabetes and other types of diabetes, the risk was around twice that of someone without the condition. So these are, of course, really worrying findings on the face of it. But I think what's really important to remember is that these studies are looking at an average picture of people who have been involved in that particular study. But our risk is unique to each and one of us. So there are lots of other things that are going to all slightly change your risk, either maybe take that risk up a bit or lower it. Things like your age, your body weight, and your ethnicity, where you live, and diabetes specific factors as well, like your HbA1c level, your average blood sugar over the past few months, and whether you have a history of diabetes complications, so that we know that those factors can all add to your risk. And when we're doing these comparisons where we're saying people with diabetes have this times more risk than people without diabetes, that always sounds alarming, but you've got to think, when we're interpreting risk, you've really got to think about what that baseline risk of something is to begin with, and we call that the absolute risk. So that's what your chances are of dying from coronavirus. So for example, if we take me, I'm a 30-odd-year-old with type 1 diabetes, and I don't have any other risk factors particularly that are linked with developing a severe illness from coronavirus. So my absolute risk, the overall risk of dying from the virus would be, if I didn't have diabetes, would be very small, it would be around 0.0009%. Because I have type 1 diabetes, my risk is elevated. So if it was 3.5 times that risk, as the research has shown us, then it would come out at 0.003%. So you can see that although our risks are higher when we have diabetes, because for most people the risks start off low, even when you increase that risk, you've still got a low level of risk. That's not the case for everyone. We of course know that there's some people who will have multiple risk factors and will be at a higher risk. But for the majority of people with diabetes, that risk is still low. And we know very few people under the age of 50 have died from the virus. So really the kind of take-home message there is a higher risk doesn't always equal a high risk. And we have to think about our own individual circumstances to fully understand what our risk might be. Also, all of this research that I've kind of that big NHS England study and most of the of these large data sets have looked at what was going on during the first wave of the pandemic, because that was the data that was available that they quickly looked at. Since then, scientists and doctors have developed a much better understanding of how to treat coronavirus, and people in intensive care are now about 50% less likely to die compared to last year. So that means that the risk of dying from the virus for everyone has already become lower, and hopefully that will get lower and lower as vaccines kick in and as we get more treatments. So the third thing that I wanted to tell you about was, what do we know about why people with diabetes do have this higher risk and are more likely to get seriously ill? Oh, sorry, someone's just told me to look at the question in the Q&A. Are they focusing, which is, are those studies focusing on type 1, type 2, or both? So yeah, these kind of big studies that are looking at the kind of the whole population of people with diabetes are looking at all types of diabetes. Some of them frustratingly don't separate out between types, but that one that I've mentioned about there, the kind of really key study from NHS England did. So we're able to know about differences between people with type 1 and type 2 and other types of diabetes as well. So yeah, going back to why this might be. So this is an area of research that's developing and that we don't really have all the answers yet. So shared risk factors will be one reason why we do see more serious illness in people with diabetes. So particularly when we think about type 2 diabetes, that's a condition that affects people in older age. That's where we see a lot of type 2, and of course age we know is the biggest risk factor. We also see higher rates of type 2 diabetes in people from Black African and Caribbean and South Asian backgrounds. And we also see higher rates of type 2 in deprived areas. People with diabetes can also live with other health conditions. That might be the complications of diabetes or things like high blood pressure. So those shared risk factors can partly explain why people with diabetes have a higher chance of a serious illness. But we also know that, as I said before, when we account for those factors and strip away the impact of them, diabetes still comes out as a risk factor by itself. So there's something else going on, the impact that diabetes is having on the body. One possible explanation could be around inflammation. So high blood sugar levels can cause inflammation inside our body, and coronavirus also triggers inflammation. So one possibility could be that people with diabetes are starting off with more inflammation to begin with, and then the effects of COVID makes that worse, so they may be experiencing that more severely. And too much inflammation can cause our immune system to go into overdrive. So that means instead of fighting an infection, as it should do, it can start to attack healthy parts of our body and vital organs. That's known as a cytokine storm, and higher levels of inflammation could mean that people with diabetes might be more likely to experience that. That could also help explain why having lower blood sugar levels if you have diabetes has been linked to reduced risk of getting seriously ill with coronavirus. Another possibility could be to do with some of the complications that having diabetes over a long period of time can cause. In particular, the damage it can do to blood vessels. So our blood vessels have a layer of cells around them which act as a barrier between our blood and tissue. And that barrier blocks certain substances from entering our tissue. And when you have diabetes, high blood sugar levels can damage that barrier over time and cause it to break down. And scientists think that this breakdown could potentially make it easier for the virus to travel around the body and infect other areas, so not just the lungs, where it primarily starts to take hold, but that it can also travel to the kidneys, the heart, the brain maybe. And this is another area that Diabetes UK are funding research into. So we're funding Dr. Miguel Bernabeu at the University of Edinburgh to look into that more. And he's studying people who have retinopathy, an eye disease caused by diabetes, to investigate if damage to the blood tissue barrier in the eye allows the virus to travel to other organs. And he'll investigate if that is the case and try to understand why, what mechanisms is it that could explain why people who have retinopathy may be more likely to get seriously ill from coronavirus. I've just seen another question come in, which is, so high blood sugar levels and causing inflammation, at what level of HbA1c can that happen? So I think there's not really a precise, just I think if you're above that ideal target of 6.5 over many, many years, then that can drive inflammation inside your body. But when we think about what we know about HbA1c and coronavirus risk, the research has kind of split A1c into below 9% and above 9%. I still work in old money, so I don't know what that is in the non-percentages that I should do. But so that's the kind of level that they're looking at. If you've got an A1c of above 9%, that's thought to add to your risk of becoming seriously ill. So that's the kind of level of high blood sugar that we're talking about here. And finally, another possible reason to explain why the biology behind why this could be happening is to do with a protein that's called ACE2 that you may have heard about, which is a receptor that's found on the surface of cells. And this is the receptor that coronavirus uses as its doorway to enter and infect cells in our body. And there's some evidence to suggest that people with diabetes have higher levels of ACE2. So that could potentially give the virus more doors to open and more opportunities to infect the body. And it could really, and what is likely to be the explanation is that it's a combination of all these different things coming together that can explain why people with diabetes have this higher risk. And with more research, we'll get a better understanding of what's happening inside the body, and that will be key to improving treatments and protecting people with diabetes from the virus. So the fourth thing I wanted to mention was, what can you do to reduce your risk of getting seriously ill if you have diabetes? Well, the most important thing is now to get a coronavirus vaccine when you're offered one, and we'll have other speakers talking all about that later, but that's certainly the most effective way to protect yourself. And Diabetes UK would strongly encourage everyone with diabetes to get a vaccine as soon as they can. In the meantime, it's really important to kind of be as stringent as you can, if possible, about following social distancing advice, mask wearing, hand washing, those measures that we all are sick of. We know that, unfortunately, some people aren't able to, work from home and protect themselves as much as they can. And we've recently, in this last wave, we've been campaigning to the government and writing to the CMOs at Diabetes UK to try and get some people who are at the highest risk on the shielding list. And based on the research, our kind of category of who we think needs to be more protected are people with diabetes who are over the age of 50, have a HbA1c of above 9%, and also have a history of diabetes complications. So people who have all those things together, we've been campaigning for them to be put on the shielding list so that they will be able to get more support, furlough payments and the other kind of financial things that become available to people who are in the shielding category, because it's, people should not be forced into harm's way. We have had a response that wasn't particularly helpful from the CMOs, saying that they weren't able to add anyone else to the shielding list at this time, but we are continuing to try and doing surveys with people with diabetes at the moment to ask them about safety in the workplace and concerns they have, and get specific experience and this evidence from our supporters and people with diabetes, that we will go back to the government with more evidence to kind of show that there are certain groups of people who aren't feeling safe at work and are being put in harm's way. There are lots of risk factors that I've kind of talked about that you can't do anything about, like your age and ethnicity, but some of the risk factors that will increase your chances of becoming ill, you can try to do something about, such as your blood sugar level. That's easier said than done to try and bring that lower, but that's something that you can be doing, just trying as much as possible to bring those blood sugar levels down. And also, if you have a high body weight, then losing weight is going to be a good thing. So it's important to kind of work with your diabetes team at the moment to try and work on blood sugar levels. There's been kind of claims floating around about, things that you could do, foods you can eat, supplements that could potentially protect you and boost immunity. And really the key here is just eating. There's no one magic ingredient. Eating a healthy, balanced diet sounds really boring, but that's by far the best thing you can do to maintain a healthy immune system. You need lots of different nutrients to help the immune system work as it should do. So there's no one particular food or nutrient or supplement that could help prevent you picking up infections. Something that you've probably heard a lot about is vitamin D. That's attracted a lot of attention throughout the pandemic. There have been some studies that have suggested a link between lower levels of vitamin D and a greater risk of catching the virus if you're vitamin D deficient or becoming seriously ill with it. But the evidence here is really mixed. Some studies haven't found a connection, and studies that have can't tell us if vitamin D is directly responsible for lowering your risk of getting the virus. So people who tend to take vitamin D supplements every day, for example, are probably a bit more health conscious. They might also be more likely to wear masks and socially distance and do other things that improve their health as well. So it's hard to kind of pick apart, is it vitamin D that's having an impact, or is it generally a kind of healthier lifestyle? So at the moment, there's the National Institute for Health and Care Excellence, Public Health England, and the Scientific Advisory Committee on Nutrition. They've kind of done a review on all of the evidence, so looked at lots and lots of different studies that have looked at links between vitamin D and risk of getting the virus in the first place, and then risk of becoming seriously ill with COVID. And they've concluded that there's no evidence to suggest that vitamin D could help to prevent or fight coronavirus. That being said, taking vitamin D supplements is something that we are advised to do throughout the winter months, and we were advised to do that before COVID came along as well. And that might be particularly important this year because we're probably getting out into the light a lot less than we usually are. And throughout all of 2020, even in the summer, we were indoors a lot more. So people probably do have lower levels of vitamin D this year. So the government have been recommending strongly that we do all take daily supplements between October and well, early March is when they say, so 2 more weeks to get in there if you haven't been taking your vitamin D supplements. And if anyone was on the shielding list, the government were actually, at the beginning of the year, they started to offer a free supply of vitamin D to people who were on the shielding list, who would have been spending more time, of course, throughout the year indoors. Just looking through the questions. I'll come back to that one in a second, I think. So finally, the fifth headline that I wanted to tell you about was research that's showing us that COVID could possibly trigger diabetes in some people or make it worse. So at the start of the pandemic, doctors started to raise concerns that this was happening, that there were new cases of type 1 and type 2 diabetes in people who had caught the virus. And since those early anecdotal reports came to light, we've seen results from larger studies that have been looking at much bigger groups of people. So one study tracked over 47,000 people in England who had been admitted to hospital because of coronavirus last year. And they followed them up for up to 7 months after they'd been discharged from hospital. And they found that about 5% of people who had been in hospital with coronavirus later went on to develop diabetes, and they weren't able to pick out if it was type 1 or type 2 that they were seeing these new diagnoses in. And they also showed that people who'd been in hospital with coronavirus were around 1.5 times more likely to be diagnosed with diabetes after they'd been discharged, compared to people of the same age and background who hadn't been in hospital with COVID. So when we think about why that could be, for type 1 diabetes, the causes are very complex, but scientists do think that viruses could be a potential trigger for the immune attack that causes type 1 diabetes. So it's never going to be a virus alone. There's lots of environmental and genetic factors that are also going on. But it's possible that kind of getting ill with viruses could push you over the edge and trigger that diagnosis of type 1 diabetes. But when it comes to this coronavirus, it's of course very new, and there's a lot we don't yet understand about how it interacts with the immune system and its longer term effects. Cases of new type 2 diagnoses have also been reported in people who've had coronavirus. One possible reason could be to do with inflammation inside the body that coronavirus causes. So inflammation can as well as being a consequence of having diabetes, it can also bring about insulin resistance, which means the body isn't able to make proper use of the insulin you're producing, and that's a prominent factor in developing type 2 diabetes. Another potential explanation could be to do with ACE2, this receptor that lets the virus enter your cells. So ACE2 is found in the pancreas and in other organs and tissues that play an important role in how our body processes glucose. So when coronavirus locks on to ACE2, the cells in the pancreas that release insulin might not be able to do their usual job. So you might end up producing less insulin. And likewise, this might also affect, how your body processes glucose and takes it from your blood and into your cells for energy. So all of that might mean that people who are susceptible to type 2 diabetes and already at high risk, it might push that progression towards a diagnosis, or bring to light already existing type 2 diabetes that hasn't yet been diagnosed. Scientists are also looking into the possibility that COVID could be triggering an entirely new type of diabetes, perhaps by directly damaging the pancreas and the cells in it that produce insulin. So there's some very, very early studies that have kind of been looking at what happens to cells that scientists have grown in the lab when they infect those pancreas cells with coronavirus. There's also been very small studies that have looked at pancreas samples from people who have sadly died with COVID, and they found evidence that the virus has infected the pancreas and the cells that produce insulin within it. So that research is certainly at a very early stage, and there's a lot we don't understand yet in regards to whether we're seeing new type 1, type 2, or this different type of diabetes. And because we don't have long-term studies yet, we also don't know whether this is a temporary, a permanent, lifelong diabetes, or whether it is just temporary. It's possible that it's just due to the stress of the infection that we see people's blood sugar levels rise, or some of the treatments that are used to treat coronavirus, some of these steroids that do cause blood sugar levels to rise in people with and without diabetes. So there's an awful lot of research going into this, and an international group of scientists have set up a registry where they're asking doctors all over the world, whenever they see new diabetes in people who've had COVID, to input that data on that particular person, and they're collecting this big body of evidence that they'll be able to do much more thorough, longer term studies that will kind of help us work out what's really going on here. But yeah, it's kind of a surprising thing that no one kind of expected at the beginning of this pandemic, that we'd be seeing potentially new cases of diabetes. So yeah, that's kind of what we've learned and what we still don't know in a nutshell. So just going back to one of the questions that I had, which is around vaccination and whether someone could go back to work if they have pre-diabetes and a heart condition, if you've had the vaccine. So, I mean, it's, I think the advice that I see from the CMOs and scientific advisors in press conferences is, if you've just had one dose, to act as though you are not vaccinated yet. We're getting more evidence that kind of shows the level of protection in between that those different doses, and you do get kind of a good bulk of protection, but it's really important to to kind of not act as though you are safe and fully protected until you have been fully vaccinated. Now, of course, this is, kind of a really difficult situation if you don't have a choice where you can work and whether you can kind of protect yourself. But that would be the kind of wait until you are fully vaccinated and you've had those 2 doses, and a couple of weeks after that has passed for that protection to really kick in.
Thank you for that. Thank you for that presentation, Faye. Do we have any more questions for Dr. Riley? If so, please use the Q&A button that's on the bottom of your screen. We'll just wait a second for people to type anything in that they might want to type in. I don't think no. No, okay, I'm not seeing anything. So I'll just close that down, and we'll thank you very much.
Thank you,
Dr. Riley. Please accept a virtual round of applause from, I'm sure, on behalf of everyone that's on the webinar. We just have one question suddenly come in on the chat screen from Harish. Does cell 2 ACE recover?
So yeah, when the infection goes away, when you've kind of fully recovered from coronavirus, then we hope that those ACE2 receptors would be freed up. Although we are seeing evidence that there's still COVID in there after death in people that have died. So I think it's a kind of yes and no. It's not as your ACE2 receptors aren't going to permanently be dealing with coronavirus that's locked on, but I think beyond the time when you may have symptoms, there might be kind of lingering impacts of coronavirus still lurking around in your body and affecting your cells and how those cells work after you've recovered from those initial symptoms. But we need these kind of longer running and mechanistic studies to kind of really see what's going on inside the body. So we don't really have the full answers for that yet. And is it a matter of regeneration? I don't think so. I think it's more the virus will kind of die and shed eventually. But yeah, this is an area where scientists are doing a lot of work and are trying to find those answers.
Thank you for that. 30 seconds for any follow-up from anybody. If not, we'll move on. Again, thank you very much, Dr. Riley. So we now move on to our next speaker, who is Rebecca Nino. Rebecca, could you unmute yourself? And let me introduce Rebecca. Is the Senior Responsible Officer for the COVID-19 vaccination programme in NHS Lincolnshire from the Clinical Commissioning Group. And we have some slides which I have got to master the technology of sharing with everybody.
Thank you, Richard, and thank you everybody for inviting me to speak to you about the vaccination programme. Needless to say, the NHS has never delivered anything on this scale before, but as you'll probably hear later this evening when our Prime Minister takes to the stand in 10 Downing Street, you'll probably get to understand just how well the programme's going nationally, but also within Lincolnshire. So I'm just going to talk a little bit about the delivery model we've got in Lincolnshire. Some of the authorisation processes that we had to go through, so just so you've got an understanding of some of the hoops, if you like, that we needed to jump through to bring the programme into Lincolnshire. Some of our planning assumptions, some of our achievements, and just some final comments and some patient feedback that I'll share. So the model that we are delivering in Lincolnshire is one of network of provider, which simply means we're using all parts of the health and to some degree social care system and our partners in what we call the Lincolnshire Resilience Forum. So they're volunteers, fire service, police, council, etc., that come together in an incident to help manage how we deliver services in its wider context, and the NHS is part of that system. When we were asked to start designing a programme for COVID-19 vaccinations, it was actually way back in August actually that we were first approached around the potential of vaccines. And of course, we didn't know what vaccines were going to be available, what mechanisms of delivery we might need. So what we built was a model which could adapt to many situations, depending upon what came over the hill really, and what we were required to do nationally. It became really clear very early on that whatever we designed needed to have access to 100% of our populations. So that's not only assuming people will come to us, but also we need to go to them. And again, very early on, we were briefed around 2 potential vaccines at that time, one being the Pfizer and one being the Oxford AstraZeneca, which almost now the general public know just as much about those vaccinations as I do. Both of those vaccinations require 2 doses, given at the moment for both of those vaccinations between 11 and 12 weeks apart, which means in Lincolnshire as a whole, we need to deliver 1.2 million vaccinations to our adult population as quickly and as safely as possible to preserve life and protect the NHS. So we have a range of sites, and I'll talk a little bit more about the different sites that we have operational, because I know it can be quite confusing, and needless to say in the NHS we do tend to make things a little confusing for people sometimes to navigate their way around, so I'll try and give some clarity around that. And very early on we were asked to think about our priority groups. And certainly the top 4 groups, which you'll hear an awful lot about if you tune into the press conference later, the top 4 cohorts, as we call them, were the groups that we were asked to plan for right at the beginning, and those groups haven't changed as we've moved through delivery. So as I've said, the cohorts and how we work through the programme are designed by the JCVI, the Joint Committee for Vaccinations and Immunisations, a national committee advising the chief medical officers of the respective nations. And the top 4 cohorts, so residents in care homes and the associated staff, the over 80s and the frontline health and social care workers, those aged 75, and those aged 70, and the clinical extremely vulnerable, who are essentially those on the shielding lists, just for clarity. They are what we call cohorts 1 to 4. We have concluded cohorts 1 to 4 within Lincolnshire as of the weekend, and in line with the rest of England. We've now moved to vaccinate cohorts 5 and 6, so all those over 65 years and over, and all those with an underlying health condition, which is, I'm assuming, where the majority of those individuals with diabetes will get called. So do be ready over the next 2 to 3 weeks, because that calls you will start receiving letters. The letters to cohorts 5, which is 65 years and over, commenced arriving on Saturday, and they will proceed during this week. And at the same time, you will see local services also beginning to call cohort 6. We then go through to what we call cohort 9. And again, I'm sure this evening you'll hear Boris Johnson talking about the next stage of the programme, where we're being asked to vaccinate everybody up to cohort 9, so everybody over 50 years of age by the beginning of May with 1 vaccination. As you will have already heard, this programme requires 2 vaccinations, so towards the end of this month we will start calling people for their second vaccinations. So whilst we've made absolutely tremendous progress in the top 4 groups, what you will see is as we move to cohorts 5 and 6 in tandem, we will also need to start calling people back at around 11 to 12 weeks for their second vaccination also. Next slide, please. So the sorts of delivery models that we were asked to put together, some people say, why on earth did you do what you did? Well, some of it was there had to be some national synergy across the models. So we were required to have large scale, we call them mass vaccination centres or sites, placed across Lincolnshire. We required 2. Based upon simple calculations across population numbers, and they are sited in Boston, the Princess Royal Sports Arena, and the showground up to the north of Lincoln. Those sites are sites that are accessible when individuals receive the national letter. So this is where it gets very, very confusing. So there are 2 main call routes for patients to have a vaccination. One is through the national booking system, which allows you to book an appointment at a large scale site. So for us, either at Boston or in Lincoln. However, for those living towards the south of the county, you can also access the large-scale sites at Peterborough as well, the City Care Centre and the East of England showground. So you are required, if you receive a letter, to either go online or ring 119, where you will get often an appointment at a large-scale centre. Alongside that, our GP services are also calling individuals for vaccinations. So the 2 streams do work together, but it can be quite confusing because the IT systems don't necessarily link. So your GP practice won't actually have any idea whether you have or have not received a letter from the national booking system, and won't know that you've got an appointment. It will only show on your GP record once you've attended for your vaccination. So GPs are also calling individuals. In Stamford, the local vaccination centre is at the St Mary's site, and the Lakeside team there are working through their practice lists to call people into those sites as well. You may also know individuals who may have been vaccinated at Peterborough City Hospital, at the hospital hub. And again, that's absolutely another pillar available, certainly in the early days before our local sites were operational. And then the 4th type of vaccination service is our roving or our outreach vaccination service. So for those individuals who are housebound, who genuinely cannot get to a centre, perhaps typically have their flu vaccination in their own homes, the local GP services will come out to you in your own home and vaccinate you if you're unable to get to a centre. So a range of different mechanisms for individuals to receive their vaccine. Next slide, please. So again, this is just, as I've really said, where our sites are, our 2 main vaccination centres. In Lincolnshire, we also have 2 hospital hubs and 13 local vaccination sites. We were in what we call the very first tranche of hospital hubs to go live in December. So the first opportunity, we took Lincoln County Hospital live. We then launched 2 of our sites in Grantham and Louth in wave 1. So because there are so many local vaccination sites to come on board, there were actually 8 waves nationally to bring them on board, and we delivered 2 in the first wave and 2 in the second and third wave, with Stamford in the 4th wave. We actually managed to conclude all of our sites in 6 waves, so we brought all of ours on board by the 2nd week of January, which when I sort of show you the assurance process, you'll appreciate was not an easy task. Not all of the local sites are run through GP practices. Some areas didn't have a GP practice that was suitable to get the volume of patients through in a socially distanced, safe way. So in some areas we've needed to contract with local venues to allow us to manage the programme safely. Next slide, please. So to get a site live, you know, it's not just a case of us saying, righty ho, we're going to take this site live. Each of these sites needed to be have an operational assessment, so to make sure operationally they were fit for purpose. Each site then had to have a clinical visit to make sure they were safe from an infection control point of view, social distancing point of view, and so on and so forth. They then needed to be visited by a pharmacy team to make sure the governance around the vaccinations in relation to the mixing of them. Some of you will be aware, particularly the Pfizer vaccine is a very fragile vaccine in its makeup, and the way the vaccine's delivered is kind of, I think about it in almost like a silk envelope, and if the silk envelope becomes damaged, then it doesn't work as well as it should. And therefore the little tiny vials that they come in need really, really sensitive handling. And not only does it require drawing up, which essentially is you know, a needle and syringe and drawing it out of the little vial. The Pfizer vaccine also needs mixing, so it needed really tight pharmaceutical governance with pharmacy oversight when we took each of those sites live from a safety perspective. And then each of the GP practices, or groups of GP practices, the PCMs, had to go through a number of what we call go, no-go meetings. We had to absolutely make sure that this was a safe process for individuals when they're visiting the sites. And so if you sort of replicate that across 13 local sites, plus 2 large-scale sites in your hospital hub, you can begin to see just how complex the programme actually is to deliver it. Next slide, please. So this just gives you some understanding of the numbers of individuals that we have eligible from within Lincolnshire. And I think my mantra throughout the beginning of the programme was the ask for us to bring the programme in, if you like, at the deadline. So the ask for us to complete cohorts 1 to 4 in the time frame that we were asked to do it was always going to be really difficult and a really tough job for us in Lincolnshire. When you compare the population to a population perhaps such as Birmingham, who after about 3 weeks had completed their population because of the way the demography is. So I'm absolutely delighted that we have in Lincolnshire kept pace with our partners. In fact, you know, as you'll start to see when the numbers are published, actually being a leader actually rather than just keeping pace, but we have kept pace with every vaccine that has been offered to Lincolnshire. We have declined absolutely no vaccines, and we have wasted no vaccine unnecessarily either, which is really, really important when you're delivering a mass vaccination programme. Next slide, please. So just some final comments, and then I'll have a look at the questions. I think there's a couple in there. So I've already said that we were part of the first group. We were actually day 2. You remember the first sites went live on the Monday. We went live on the Tuesday at Lincoln. And similarly, we then did the same thing for our local vaccination sites, and then we were actually day 1 of the Oxford AstraZeneca hospital hub that we ran at Pilgrim as well. And that slide just gives you a little bit of an idea of how quick we were able to mobilise in Lincolnshire with regards to when the first vaccine was approved. And actually the first date we were actually vaccinating in Lincolnshire was actually 6 days, in line with a few other counties. The vaccination centre at Boston was the first in East Midlands to go live. We were in tranche 2, the only other one was in Birmingham. So some real great work from the team to get this vaccination into Lincolnshire and start vaccinating our population. There are some data on there. That was the data as of the beginning of last week. So a week ago, we were at 93% of our over 80s and 81% of our 79 to 75. The results are higher than that, and they are all in their 90%. So really great, great achievement. What we're now looking looking forward really now in where we take the programme next. So whilst we've done a great job, if you like, in cohorts 1 to 4, there are a number of cohorts still to go. We've got cohorts 1 to 4 vaccinated with 1 vaccination, and as you heard Faye mention that you know, the restrictions on our lives continue with 1 vaccination. So we need to work as quickly as we can in ensuring that we get those second vaccinations in people's arms, get them fully protected. Think about how we're going to sustain that model of vaccination as we move down the cohorts of individuals, as we get through into the younger population, and then possibly into the territory of booster vaccinations in the autumn, as the government already talking to us about, as we continue to maintain the protection we're going to need as new variants come forward. Patient feedback, it's not surprising, has been really quite positive. And if you just go on to the next slide, Keith, there's some quotes there for you to see. Notwithstanding, as I've said, the most difficulty I think we have is navigating people into the service, because it is a little bit confusing. Once people get there, they are absolutely grateful for that vaccination. So I think at the minute the messages are, if you are in one of the top priority groups, so priority groups 1 to 4, you were shielding and you have not yet been called for your vaccination, then please do contact your GP practice. They are waiting to vaccinate you. If you're in cohorts 5 and 6 and the other cohorts, please do wait. We will contact you when it is your turn. If you're in cohorts 5 and 6, that will be imminent over the next few weeks. So please do be ready to attend for your vaccination when called. What I will do, if that's okay, I'll have a look at the question and answers. So I've got one: will there be any more vaccination centres opening? The answer to that, in the immediate future as a full-scale vaccination centre, is no. What we are doing in some localities where we may have a group of patients who cannot get to a site but don't necessarily need a housebound visit, then we are able to run what we call pop-up centres, pop-up vaccination centres in GP practices to make that a little bit more accessible for people. But at the minute, we don't have any specific plans to open more vaccination centres. What we do know is, as we move through the programme and those that we vaccinate potentially become more mobile, our pharmacists may play a larger role than what they play currently. So we may see some pharmacists opening in Lincolnshire to help us along with that, but currently at the moment no more large scale vaccination centres, but we do keep the programme under regular review. So what controls and checks are there to ensure the Pfizer vaccine is properly mixed? Well, there is what we call a really tight standard operating procedure, and the vaccine is overseen as it is mixed and prepared by 2 individuals who have gone through rigorous training and have been signed off as competent to do that. So yeah, huge amounts of controls around how that vaccination is handled. Has there been many people not turning up for the vaccination? So we do have a number of DNAs do not attend each day. What we tend to find is that is actually because of the confusion of access, rather than people booking an appointment that they don't want the vaccine. So what potentially can happen is you receive the letter, patients will book an appointment at a vaccination centre, perhaps at Peterborough, and then the next day your GP practice phones you and says, please come along for the vaccine. And you choose to go to your local site before, without cancelling the booking at the main site. So we do know that's an issue. It's not a huge problem at all, and digitally we're trying to find, as they are nationally, a solution to that issue. But there are currently more than enough slots available within Lincolnshire for people to get their vaccination, for us to keep pace with the vaccine that's available to us. You'll have heard the government talk about the rate limiting factor being the vaccination, and that is absolutely the case for us in Lincolnshire. We are allocated vaccine each week into various sites. That is a national process that happens based on the population. So you know, we are then able to take that vaccine or redistribute that vaccine. And actually what we've seen is we've actually took every vaccine that's available, and actually we've took more as it's become available during the week. We often get an SOS, we've got some vaccine, can anybody take it? And we're usually at the forefront of bringing in additional vaccine into Lincolnshire. Are we doing anything to negate the false messages floating on social media? It depends what false messages, I guess, people are referring to. If we're referring to the anti-vax campaign, absolutely. I mean, nationally, we are there's a whole raft of work happening around the myth busting, if you like, around the vaccinations. What we're seeing at the moment is in the older cohorts that we've just vaccinated, the level of uptake that we've seen, we've not seen vast amount of anti-vax material impacting upon that uptake. But what we are doing is preparing for that to become a larger issue as we move down the cohorts. So, you know, there's certainly the issue of does the vaccine affect fertility, for example, that, you know, may be an issue as we start vaccinating other groups of individuals. Again, in Lincolnshire, we've not seen the issues in our health and social care worker cohort as other areas have. So actually, Lincolnshire is a really high performing when we look at our BAME populations through the health and social care worker route, and actually we've advised other areas on what we've done to drive uptake in some of the groups who have got some reticence of having the vaccine. So there's lots to learn, if you like, within that group. If someone is shielding at a different address to their GP's given address, i.e. a student now returned home, how will they be invited for vaccination? So if you are living, so if your GP is in Oxford and you're living in Lincolnshire, the simplest thing that you can do is go and temporary register with one of our GPs. And then you will be called when it is your turn. If you are within the cohorts 1 to 4 or cohorts 5 or are a health and social care worker currently, you can go on to the national booking system. The national booking system is open. The website is open, and you can book an appointment at actually any vaccination centre in England. It doesn't need to be near where you live if you so wished to travel 200 miles, despite it being obviously illegal because we're in national lockdown. You could book an appointment. So 2 main routes, either through the national booking system to book an appointment at a local vaccination centre, or if you are in Lincolnshire for a given amount of time and you are not registered here, my advice would be clearly to register as a temporary resident in Lincolnshire, because that will ensure your eligibility for the vaccine. I don't think I can see any more questions, Richard, unless I'm missing any.
No, nor can I. So thank you very much indeed for that. It was a very, very informative talk, and we're very grateful for your time to come and talk to us today. No more questions. Thank you very much. And we'll now move on to Lynnette. Hello, Lynnette. If you could unmute. Just need to unmute you.
Hello.
Sorry about the delay. Thank you very much.
Thank you. As I say, my name's Lynnette Pryke. I'd like to tell you about my COVID journey. It starts actually on January the 1st, 2020. I'm an avid diary writer, and this was my entry into 2020. I'm not doing any resolutions this year. I usually break them by the 4th day anyway. I had a massive disagreement with Heather. Now, Heather is my older sister, and she's very high up in the NHS. She told me off for scaring Mum. All I said to Mum was that I was worried about what was happening in China. I told her that she should make sure her freezer was topped up because I was sure this was going to be a world pandemic. She had to make sure she had paracetamols, toilet rolls, and Milton's sterilising tablets. I also told her that I would order her a nebulizer and some saline nebules just in case. I've also ordered 2,000 face masks, FF2 type. I have a hunch that we might need them. I've also found a pattern to make cloth ones with a little filter pocket in, and I've ordered 1,000 filters. Oh, and 20 litres of hand sanitizer. I've sent Mum 10 litres of hand sanitizer too. If I've got this wrong, then I will be wearing face masks for furniture restoration for the rest of my life. So they won't go to waste. And Heather will have the pleasure of telling me that she was right. So that was my first entry on January the 1st. Subsequently, my elder sister has told me that I got it right. On March the 16th last year, I decided to close my little furniture shop because I could see how the pandemic was going. On that day, I decided to set up a Facebook group to support my customers. Many of them were elderly. And I was very, very concerned that there was going to be a lot of misinformation flying around, which could worry them. I live in a little place called Sutton-on-Sea, but my shop was in Alford. And as I say, it's predominantly an aged population. I also had a stroke 6 years ago, and I have brittle asthma and a degenerative spine. So I knew that I was going to be in the extremely critical, vulnerable shielding group. So I thought if I set this little group up, we could all support each other, and whatever happened, we would get through it. So I set up the Alford Hub. We've answered since last March 46,000 questions and help requests. We have a team of 120 volunteers, which I coordinate, and we have delivered 1,800 prescriptions to people in the shielding group. I've launched a virtual community centre through Facebook, where we do daily toddler sessions. We also do coffee and chat. Magna Vita come in and do a well-being and armchair exercises. We've had diabetes talks. We've had virtual job fairs, and we support people's mental health. I've also launched a uniform bank for the local schools, a baby bank. We have a hospital discharge team. We also have a COVID isolation team to help people isolate who were COVID positive. And most recently, I worked with the schools to set up the mass testing sites for when the children returned, well, the key worker children returned in January. I did all that whilst shielding. My background, I've had over 30 years experience in voluntary management, and I did my pandemic training 17 years ago. I always laugh because when we did the training, one of the tutors said, "Don't worry, you'll never need it. You'll never need this training. It will never happen in the UK." And I can always remember that. Everything was going fine. We were supporting people through the hub, and it was very well received. It also became the place where we shared the government's policies and the government posts. It was recognised as the official notice board, virtual notice board, where people could get trusted information, and that was a really important thing. This wasn't like in the war, because society in lockdown shut down, and we needed to provide a place where people turned to for that advice, and Alford Hub was able to do that. From March to October, everything was going fine. As I say, I was still in the shielding group. We were homeschooling my children as well, and unfortunately, when my children returned to school after half term in October, my 17-year-old daughter contracted COVID. She came home from sixth form and told me that I may have a phone call from school because a boy had turned up into school with COVID symptoms and she told him off for coming into class. He said that COVID wasn't real. That's what his parents had told him. He took his mask off and he coughed on my daughter and her two friends. Unfortunately, 5 days later, my daughter came down with symptoms. Now, at this point, because we were shielding, straight away, we decided, when my daughter told us what had happened on the day at school, before she tested positive, we kept my 11-year-old off school as well, just as a precaution. Thankfully, we did, because my youngest daughter then tested positive. My husband had to look after the pair of them, and I tried to distance myself in the house as much as possible. There was nowhere for me to go. And unfortunately, my husband caught COVID and he nearly died twice. I then had to nurse all of them and I got it and I ended up in hospital. The strange thing was all four of us presented completely differently. And my 17-year-old who is going on to drama school, so she's extremely fit, dancers and what have you. She started with the classic cough, high temperature, and she was absolutely bullet points from what the government had been saying the symptoms were. My 11-year-old had no symptoms at all, and had she been an only child, we would have had no reason to keep her off school. On day 3, after she'd had the positive test, because we got her tested because of my eldest daughter, she had what I can only describe as a red hue to her skin from top to toe. Wasn't a rash. It looked like a filter, one of the Snapchat filters that, you know, the children all use. And she was bright red, but she didn't feel ill at all. My husband had the hacking cough and the temperature, and I didn't. To start off with, it was the bad headache. And I can only describe the headache as it was far worse than my stroke and encephalitis 6 years ago. I didn't realise that I could experience such a level of pain as the COVID headache. On day 7, that's all I had was the headache, no temperature or anything, just this really awful headache. I was very relieved because I thought I'd come away quite lightly, really, with having brittle asthma and being nebulizer dependent with my asthma. The last place I wanted COVID to go was on my lungs. Unfortunately, on day 7, I took a nosedive, ended up in hospital. It went on my lungs on day 7 and I ended up with COVID pneumonia. It's obviously, I'm so grateful that we all survived. As you can see, we'll address the elephant in the room. I'm on oxygen. I have brain fog. I still have really bad headaches. It's left me with permanent lung damage. It's left my husband with permanent lung damage. And it's also left me with scarring on my liver, which I've never had any liver problems. I'm not a drinker, that's not my bag. So that was quite shocking. One of the other things it's done is it has made me super sensitive to having allergic reactions to things that I wasn't having any reactions to before. It's I can eat something one day, be absolutely fine, have something the next day, and my head starts swelling. I'm also very aware of my teeth. I can feel my jaw and feel my teeth. The fatigue's awful. Now, when I had my stroke and encephalitis, it left me with ME. I had a virus which caused my encephalitis, and so my ME was very post-viral. In a way, I feel quite fortunate because I can sort of make the comparison between post-viral ME and COVID fatigue. And for me, it's exactly the same. It's left me with sleep reversal. For those that that don't know what that is, you can be awake all night and you can feel very, very tired in the day, but your sleep isn't refreshing. Now, throughout all this, I kept Alford Hub going, and I also, one of the things that I do, you'll have to forgive the brain fog, the I know it's very annoying. One of the things that I do is I volunteer and I work with LCVS, and I support the other voluntary groups, and I'm also helping overseeing the launch of 70 other groups up and down the country that provide the help and support that Alford Hub does. I think that COVID, well, for a start, it's changed my life. I don't think we will ever go back in society to sort of the pre-COVID state. I think we're going to be a new improved society from it. And the reason that I say that is before COVID, nobody would employ me. Why would they employ somebody with multiple health issues that falls over all the time, that has brain fog, can write a letter and ask for an elephant to put the letter in, and automatically I'll know that my brain, I'll go, I don't really want an elephant, and I know the right letter, but my brain will fill the blank in. Why would anybody want to employ me? What COVID has done for me, it allowed me to prove not just what I could do, but what also people with chronic illnesses could do. Out of my 120 volunteers, a large proportion of them have chronic diabetes. We have a lady that is totally deaf. We have people without limbs. We have people with mental health issues, social anxieties. And what I wanted to do was create a volunteering platform, multiple platforms, where we matched their volunteering and their skills to their limitations and to their restrictions with family, with jobs. And we've done it. We've absolutely done it. Our mass vaccine centre at the school was one of the first in the country to be up and ready for when the children went back to school. We have the virtual community centre. It wasn't doing what I wanted it to do on Facebook. So rather than just accept the limitations of Facebook, I got in touch with Facebook and challenged them to sort this out for us. They challenged me to get on board and help them sort it out, which I did. And we've done it, and it's such a useful resource. Our Facebook admins, as I say, some of them are completely deaf. They've wanted to volunteer for years and years, but never been given an opportunity because of their disabilities, because of their illnesses. They felt that they didn't have a place in society. They felt as though they couldn't have a purpose. We have been able to change that, and the voluntary sector has been able to rise up and to show society that people with chronic illnesses shouldn't be written off. We need adjustments, absolutely. We need to attend hospital appointments more than the average person. But what we've also proved is how much you can do working from home. Now, that in itself is absolutely a breakthrough for anybody that's got a chronic illness. You know, the very fact that we don't have to travel anywhere is a huge bonus. We can have our meds on the table behind our computer systems. You know, like me, we can have my oxygen. Whereas this is our time to rise up. Where do I think that we're going to go in the future? I hope that people with chronic illnesses will stand and be counted and look at what they can offer and focus on what they can offer rather than what they've lost because of their chronic illness. Many, many years ago, when I qualified as a CBT therapist, I never thought that it would take a pandemic for us to look at society and to really appreciate each other's strengths. And that's what's happening, and this is what we've got to carry forward. I'm going to just go to the questions and answers. Let's have a look. I'm not very technical, so you might get a lot of elephants. So, yeah, Alford Hub is very much on the connect to support, and we champion that because it's a great resource. It's a great resource for everybody, every member of the community, to see what's available to them locally. Thank you. Thank you for saying so. Somebody said that you're very brave to share something so personal. I wouldn't say that I was brave. I feel very privileged that I have been in a unique position where not only was I in the shielding group, also homeschooling my children, setting up the hub, working with government panels. I find myself in a Zoom with Boris Johnson. I found myself in Zooms with the Chancellor, championing what volunteers can do and championing people with disabilities and saying, look, you know, take us serious. We might have an illness, we might have a disability, but we've still got so much to offer society. And I think my role moving forward is to carry on doing these talks, pushing forward. And if I have to be a champion for the long COVID and for disabilities, then so be it, because together we're in this and together we can make a brighter future. I truly believe that. Thank you.
Thank you very much, Lynnette. That was wonderful to hear from you, all of those things that I guess none of us have heard before. So it was very moving for me, and I hope I can speak on behalf of everybody else when I say that. Does anyone else have any questions for Lynnette, please? Please don't be shy.
Mm-hmm.
Okay, well, Lynnette, I hope we'll be able to pass some details on for people that want any follow-up. And if you let us know, we'll add that on again onto the end of the video that will go up on our YouTube channel, hopefully within 48 hours time. And that link will go out as the follow-up email from Zoom to everybody that's registered for this webinar. Okay, now, thank you very much again. Keith has asked me to give a few adverts, I suppose, just to say what we're doing now as a charity. As I think I alluded to at the beginning, we do have a full program of events planned for the coming months. And the next event is going to be on Monday, the 15th of March, again from 2 till 4. And in this webinar, we are going to be telling you all about the different community support groups which support the NHS and support health education around locally. And we will have representatives from Health Watch, that's Lincolnshire Health Watch, who will tell us all about their services, giving various reports on different aspects of health services. We'll also be hearing from a group called Social Prescribing, who identify social activities that can assist people's well-being. And we will also have a presentation from Evergreen, whom many Stamfordians I'm sure will have heard of, about the different services they have to assist the elderly to live independently. So do join us for the next one. We will be in touch. We've got your email addresses. We will be in touch to get GDPR clearance from you to keep your email addresses and have you permanently on our mailing list for future events. We really also encourage your feedback from this first session. This is our first session. Apologies if it's not been as slick. We're not used to doing these things perhaps as much as we should be, but I'm sure that we will soon get used to it, because we've got a whole program of things planned, as I say, for the rest of the year. The one after that, actually, we've got another one coming up on the 29th of March, which is intriguingly entitled, certainly for someone like me who loves food. It's called Food Misuse and Food Use and Food Misuse, which is being hosted by a group called 1U. So that is I'm sure that's going to be interesting. I know I'm going to find it interesting. So again, please give us your feedback on what you've heard today. Give us ideas for future events. Thank you very much for attending. Keith, I'm looking at you. Is there anything else I need to say to everybody before we wish everybody a very good afternoon? I'll just unmute you. Sorry, I think you should say something, Keith.
Thank everybody for attending. I hope that you found it useful and interesting. Certainly, Lynnette has been inspiring, and you know, I wish to maintain a very good contact with Lynnette. We certainly have a number of events. Hopefully, we'll cover from elderly down to young children. And we've got 4 programs for that group, looking at relationships, and I'm quite excited for the things that are going to come in the future. So I thank the presenters who've done a brilliant job. Rebecca is on holiday and done it today, so I'm very special thanks for Rebecca. And hope to see you next time. Thank you.
Thanks, Keith. Cheerio, everybody.